I be if I was to leave when you need me most? I'm forever keeping my angel. How would I be if I was to leave when you need me most? I'm forever keeping my angel. How would I be if I was to leave when you need me most?
Cheers to the ones that we got. Cheers to the wish you were here, but you're not. Cause the drinks bring back all the memories of everything we've been through. Toast to the ones here today. Toast to the ones that we lost on the way. Cause the drinks bring back all the memories. And the memories bring back you. There's a time that I remember when I didn't know no pain. When I believed in forever and everything would stay the same. Now my heart feel like December when somebody say your name. Cause I can reach out to call you, but I know I will one day. Yeah. Everybody hurts sometimes, everybody hurts someday. Yeah. But everything gonna be alright. Gonna raise a glass and say, yeah. Here's to the ones that we got. Cheers to the wish you were here, but you're not. Cause the drinks bring back all the memories of everything we've been through. Toast to the ones here today. Toast to the ones that we lost on the way. Cause the drinks bring back all the memories. And the memories bring back you. Memories bring back you. There's a time that I remember when I never felt so lost. When I felt alone, the hatred was too powerful to stop. Now my heart feels like a never, and it's lighting on the dark. I got this darkest for you that you know I'll never drop. Hey. Everybody hurts sometimes, everybody hurts someday. Yeah. But everything will be alright. Gonna raise a glass and say, yeah. Cheers to the ones that we got. Cheers to the wish you were here, but you're not. Cause the drinks bring back all the memories of everything we've been through. Toast to the ones here today. Toast to the ones that we lost on the way. Cause the drinks bring back all the memories. And the memories bring back you. And the memories bring back you. I will always remember the day you kissed my lips, light as a feather. It went just like this, no, it's never been better. That summer of 2002, ooh, we were only 11, but acting like grown-ups, like we are in the present. Drinking from plastic cups, singing love is forever and ever. Well, I guess that was true. Ooh, ooh. Dancing on the hood in the middle of the woods on an old Mustang, where we sang songs with all our childhood friends. And it went like this, say, oops, I got 99 problems singing bye, bye, bye. Hold up, if you wanna go and take a ride with me, better hit me, baby, one more time. I paint a picture of you and me on the days when we were young, singing at the top of both our lungs. Now we're under the covers. Fast forward to 18, we are more than lovers. Yeah, we are all we need, and we're holding each other. I'm taken back to 2002. too. Ooh, ooh, dancing on the hood in the middle of the woods on an old Mustang where we sang songs with all our childhood friends. And it went like this: say, oops, I got 99 problems singing bye bye bye. Hold up, if you wanna go and take a ride with me, better hit me, baby, one more time. I paint a picture of you and me on the days when we were young, singing at the top of both our lungs on the day we fell in love. Ooh, ooh. On the day we fell in love. Ooh, ooh. Dancing on the hood in the middle of the woods on an old Mustang where we sang songs with all our childhood friends. Now it's like, oops, I got 99 problems singing bye bye bye. Hold up, if you wanna go and take a ride with me, better hit me, baby, one more time. I paint a picture of you and me on the days when we were young, singing at the top of both our lungs on the day we fell in love. Ooh, ooh. On the day we fell in love. Ooh, ooh. On the day we fell in love. Ooh, ooh, ooh. Singing at the top of both our lungs on the day we fell in love. There goes my heart beating, 'cause you are the reason I'm losing my sleep. Please come back now. There goes my mind racing, and you are the reason that I'm still breathing. I'm hopeless now. I climb every mountain and swim every ocean just to be with you and fix what I've broken. Oh, 'cause I need you to see that you are the reason. There goes my hand shaking, and you are the reason my heart keeps bleeding. I need you now. If I could turn back the clock, I'd make sure the light defeated the dark. I'd spend every hour of every day keeping you safe. I'd climb every mountain and swim every ocean just to be with you and fix what I've broken. Oh, 'cause I need you to see that you are the reason. I don't wanna fly no more, I don't wanna hide no more, I don't wanna cry no more. Come back, I need you. You are the reason. Come a little closer, no, just a little closer, no. Come a little closer, I need you to hold me tonight. I climb every mountain. Assalamualaikum warahmatullahi wabarakatuh.
Good evening, fellow colleagues all over the world. I am Diki.
And I am Dr. Dian. Together, we are the master of ceremony of today's webinar.
On behalf of the Society Respiratory Care Indonesia, welcome to
Respina
Respina
Global
Global
Sharing
Sharing
on
on
COVID-19
COVID-19
pandemic.
pandemic.
As we know that COVID-19, which is caused by SARS-CoV-2 virus, has been spread all over the world since December 2019.
It has infected 5.8 million people and caused death to 360,000 people globally.
World Health Organization has declared COVID-19 outbreaks as pandemic since March 12, 2020.
Today, there is no specific vaccine or medicine for COVID-19. Many treatments are still under investigation.
We need global collaboration, working side by side to accelerate the development of safe, effective, and affordable COVID-19 diagnostic, therapeutics, and vaccine.
So, tonight, we are inviting experts from around the globe to share their experience in combating COVID-19 disease.
Thank you for your enthusiasm in joining us tonight in this webinar. If you have registered, please remember to fill and submit the process for electronic certificate after the webinar.
This webinar can also be seen live in Respina Indonesia YouTube channel. If you have any question, please write down the question in Q&A section for Zoom and in the live comment section on YouTube. And please mention the name of the speaker you want to ask.
First, we are going to hear welcoming speech from the President of the Society of Respiratory Care Indonesia, Dr. Wahyuningsih Suharno, pulmonologist. Dr. Wahyuningsih, the time is yours.
Distinguished guest participants, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh. And very good morning, good afternoon, good evening to all our honorable speaker, guests, and all participants. First, I would like to thank every for allocating time in their busy schedule during this global pandemic to attend this international webinar on Respina, Respiratory Care Indonesia, with special theme Global Sharing on COVID-19. Special thank we would like to forward to President of Indonesia, President of Indonesia Medical Association, Dr. Daeng Fakih, SHMH, Honorary Speaker, Professor Dr. Venugopal MD from USA, Professor Dr. Cesare Gigoretti, MD from Italy, Professor John Hertz, PhD from UK, Professor Naoto Morimura, MD, PhD from Japan, Professor Fiona Leit, MD from Australia, Dr. Puan Serhon from Singapore, Professor Dr. Minaldi Rasmin from Indonesia. From the bottom of my heart and all those involved in the convening this webinar, in very short time during these unpredictable circumstances, I express my sincerely gratitude. Thank you also to Daria Faria Company for support this webinar event. It is great pleasure to join you today to introduce this webinar on sharing knowledge from global on COVID-19. In just a few months, we have seen how the coronavirus has changed our lives and how much suffering it has caused across the world. This new disease, with all of its unknown behavioral impact, driving our effort and innovation that we could do. Our health system, as well as a social service provider, have been restricted to their limited. Put aside other social economic shock that caused by this unpredictable crisis for many years to come. With all this situation, sharing knowledge, experience, ideas, thinking, and thoughts globally across all borders become crucial and essential. I am therefore delighted that so many experts and organizations have joined us today for this important sharing session and discussion on the respiratory care on COVID-19. Your view and insight on this are crucial for us to understand more so we could prevent, respond, and manage properly of the cases or related cases. Plus, I hope all of us can take the benefit from this event, and thank you for joining, and please enjoy the webinar. We sincerely apologize for any inconvenience during the preparation, implementation, and follow-up of the event. Without making longer, now we would like to ask the President of Indonesia Medical Association to give opening remarks, Dr. Daeng Fakih, SHMH. Thank you.
Thank you, Dr. Wahyu Ningsih. Next is the opening speech from the President of Indonesia Medical Association, Dr. Daeng Muhammad Fakih, Bachelor of Law, Master of Law. Dr. Daeng, the time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Yang saya hormati Dr. Wahyu Ningsih sebagai Ketua Respina dan Profesor Minaldi Rasmin yang alhamdulillah sudah bekerja keras bersama-sama kawan-kawan Respina, kemudian bersama Daria Faria sudah menyiapkan Respina Global Sharing on COVID-19 Pandemic ya, malam ini. Tentunya for all participants, welcome in this session and thank you for joining to discuss about COVID-19. And so thank you very much for all speakers from any countries. Yeah. I think they are incredible speaker, very incredible speaker, because they have a lot of experience, and so they have expertise within COVID-19. Here they have joined with us. Professor John Haas from UK. Very thank you. Professor Reddy from USA. Professor Cesar Gregoretti from Italy. Professor Fiona Lake from Australia. Dan of course Dr. Pua Senhor from Singapore. And once again, I'm on behalf of Indonesian Medical Association, want to say thank you very much for all speakers and highly appreciation from us. You are willing to share here about experience and expertise. So of course, we want to hear your suggestion and your recommendation how to handle COVID-19. Dan pada partisipan dari dokter-dokter Indonesia, malam ini mohon dimanfaatkan sebaik mungkin untuk menggali experience dan expertise dari speaker dari luar negeri ini. Plus satu speaker andalan kita, Prof. Minaldi Rasmin, untuk memperoleh sebanyak-banyaknya pengalaman beliau-beliau dalam menangani COVID-19 di Indonesia, sehingga sangat bermanfaat bagi kita dokter-dokter Indonesia ke depan menangani pandemi COVID-19 di Indonesia supaya cepat selesai dengan baik dan masyarakat kita segera kembali ke kehidupan yang lebih baik ya. Sekali lagi selamat kepada Respina melaksanakan seminar ini, pertemuan ini dengan baik, dan semoga pertemuan ini bermanfaat bagi kita semua. Terima kasih. Billahi taufiq wal hidayah. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Daeng Muhammad Fakih. And now we are welcoming our moderator for today. He is a professor in pulmonology and respiratory medicine, Universitas Indonesia, specialist in interventional pulmonology, respiratory emergency and critical care, chairman of Expert Board Indonesia Medical Association, chairman of Academic Senate, Faculty of Medicine, Universitas Indonesia, national clinical practice investigator of WHO Solidarity Trial on COVID-19, member of Drug Safety Monitoring Board on the use of Indonesia Herbal on COVID-19 clinical trial by Ministry of Research and Technology, National Board of Research and Innovation, and also case manager consultant of Persahabatan Hospital, Persahabatan Hospital Command Team on COVID-19.
Professor Minaldi Rasmin, pulmonologist. Professor, the time is yours.
Thank you to Dr. Diki and Dr. Dian. From Jakarta, Indonesia, I welcome you all, the international faculty members of Respina, dear invited speakers, and of course to all participants. There are registered 2,200 participants, including 1 from Australia, 1 from Egypt, 8 from India, and 2 from Malaysia. May we extend our apology because we can only make it for webinar for the 1,000 first 1,000 participants, but the rest will be also can join this through the YouTube. Anyhow, all the participants have the opportunity to raise questions through the Q&A mode, and all the questions will be answered at the end of this presentation. I hope will enjoy the sharing from our invited speakers. Slide. On behalf of the host, I will first deliver my presentation. This is my first slide. We have to fight the pandemic. Kok macet? Macet. Okay, as we see, that due to the formal data this evening at 3:30 p.m., the government released the data of the new cases, 25,773 confirmed cases, with the 557 new cases. 7,000 are relief and 1,573 are death cases. And this is this data shows that we are still in Indonesia increasing in the number of patients. If you see this slide, you will note the ODP and PDP. It means that the ODP is the patient with the contact positive but without symptoms, and PDP contact positive but with symptoms. And we see that report came from all the 34 provinces in Indonesia. So all provinces in Indonesia are already affected by the COVID-19. Number of confirmed cases is still increasing. New cases per day also increasing. New cases per day on April are around 300 to 400 cases, but now at the end of May is increased to 600 cases per day. But relief cases is increasing and death cases is decreasing. Death cases or mortality rate was 10% on March, but now is 6% at the end of May. What is the challenges? This is our challenges. The large and wide country, and as we know, Indonesia is an island country. Not so easy to go to anywhere at the same time at the shortest time. We need times and we need all mode of transportation. The other is the large number of population. We have 265 million now, and we have also tradition. Mudik, we call it mudik. Mudik is the visiting family at the rural area on special occasion or holiday, like at Eid Mubarak. This is a public movement in and out from places to other places. So this is really a movement from people to several places, and this also including contacting one people to the other. The other is many people work abroad and they are now coming home. There are 100 coming home every weeks, and the last will be the personal discipline. So many people show that they are disobey to the regulation, and this is really also our problem. But still good news in Indonesia. The good news are people became used of the work from home system. We are now using the internet, using the computer since the school children up to the workers. They use all these materials from home and they work from home, they school from home. More research activities, and even we are now producing ventilators and self-protecting devices. Also, we are increasing collaboration and support between people. Now we see that more people are supporting all the hospitals to help the hospital fulfilling the need of the facilities. Issues. What is the issue now? The issue now is being discussed every day is the new normal era. What kind of issues? What new normal is for Indonesia? This is still under discussion. For so many people is discussing this right now. How do we have to cope with it? And do we have to leave all our traditional way of wisdom? This is not maybe medical issues, but anyhow, this is a social issues, and this is really big for us in Indonesia because we have too many people, and we have still tradition, we have still wisdom. So we need to coping with all this, and especially with the news issues. Thank you. Maybe we can discuss it in the Q&A session. All participants, now I already ended my presentation. I will invite Professor Naoto Morimura. Professor Naoto Morimura from Japan is a professor in the Department of Acute Medicine, Critical Care, and Emergency Medical Center at the University of Tokyo Hospital. Professor Morimura, I invite you to present your experiences, your idea, your solution, your opinion, whatever, because all the participants will hear it from you. Professor Morimura, the time is yours. Dozo.
Okay, thank you for your introduction, and ladies and gentlemen, and good evening. I'm Naoto Morimura from Japan. Okay. Sorry. Okay, so first of all, I greatly appreciate all staff of Respina for giving me such a very important opportunity. First of all, I would like to express the deepest condolences to those who lost lives from COVID-19 and also express my sympathy to all patients who are fighting the disease. I also pay tribute to all healthcare providers and workers who respond. So although I will provide you only a few experiences as the director of my hospital emergency department and also as a medical advisory board member of the Tokyo Metropolitan Government, I would like to share our experience with you. Okay. There's no COI. So this is the menu. Okay. First, I would like to talk about national trends and policies. Okay, this slide shows the national data. Cumulative number of confirmed as COVID-19 is approximately 17,000 and 700, and so death cases are 874. Okay, this one shows basic policies for COVID-19 disease control by the government. The first strategy is observation at partitioned environments, for example, such as hotel for those who return from China with charter flight. Since the number of infected people has gradually increased with the increase in the number of travelers and returnees from each country, government switched to a policy of striving for early detection by actively introducing the PCR test. And at this stage of further increase, basic policies are investigation of link of cluster and also self-restraint on request to citizens. In order to reduce the transmission, investigation of link is very, very important. As a result, easily transmitted environment can be detected. Then we should make catchphrases. This time we made 3 C's, the 3 conditions that facilitate the transmission of infectious disease. First, closed spaces, crowds, and cross contact. in Japanese, mippei, mishu, misetsu. Then we made guideline and manual for public relations. Okay, so how did Tokyo fight against COVID-19? I would like to summarize the activities. So this slide shows the overview of Tokyo response to the first big wave. Blue line is daily new confirmed PCR positive patients. And gray is daily total number of in-hospital patients on each date. And in addition, orange is the number of serious patients on each date. And orange line is the daily number of ambulance diversion. So the Tokyo Metropolitan Government has issued two major medical alerts on April 3 and also on April 9 to all hospitals in order to request to prepare about approximately 3,000 beds. But these alerts were too late, and unfortunately, ambulance diversion occurred, as this slide shows. As of May 29, there are about 5,000 confirmed patients, including 302 dead cases in Tokyo. Okay, next issue is about treatment. So this is the activity of our academic association. And two associations related to emergency medicine have stated the conceptual model about acuity. So this angle represents predicted acuity. So severity and phases and risk factors determine the acuity of each patient. So based on this model, an evaluation flow of acute level was created. And this chart is used at health centers, clinics, telephone consultation centers, and during medical observation at hotels in order to realize right place, right time, and right patient. Okay, so let's move on the in-hospital management. This is a concept of severity classification by a research group of Ministry of Health and Urban Welfare in Japan. Components of severity is oxygen saturation and clinical symptoms. So this is the data from a database that was created by the Academic Society just after this episode about cumulative results of ECMO treatment. So of 652 patients with ventilator cases, mortality is at about 21%. The number of ECMO in Japan is 155 cases as of May 27, the day before yesterday. So this database showed high survival rate if ECMO was weaned within 15 days. In addition, shorter interval from intubation to ECMO and younger age high survival rate. Okay, so finally, I will present you about further problems. At the beginning of this week, the government lifts the declaration of emergency for all regions, and the Tokyo metropolitan government also starts to restore the healthcare system. Okay, this is a summary of problems of the first wave. Many issues remains, many challenges. The rise of replacement of headquarters, spread within several hospitals in Tokyo, and risk communication, especially among different specialties of medical staff, including doctors, and performance of diagnostic or screening test, including PCR test, and ambulance diversion, and also delayed timing of start of scalable hospital bed strategy. Especially in these programs, in order to gradually increase the number of beds and respond in this way, the timing of medical alert is key, very important. So how can we detect the next wave? So focusing on the slope is very, very important. This is one example. This orange line shows the number of changes from previous day of weekly moving average. Okay, finally. So how to decrease incidences, how to detect the cases rapidly and widely, and how to detect next wave as fast as possible, and how to change shift of response level to surge capacity immediately. Yes, this is the first problems, I think. Thank you so much. Thank you for your attention.
Thank you, Professor Naoto Morimura. I think we get a clear and very informative presentation from Professor Morimura, and we will wait for your questions. Please raise your questions through the Q&A mode, and we will collect it. The next will be our honorable speaker from the United Kingdom. It will be Professor John Hurst. Professor John Hurst is a professor of respiratory medicine at the University of College London. He is an honorary consultant physician at the Royal Free London NHS. Professor John Hurst, please.
Professor Manaldi Rasmin, dear colleagues in Respina, good evening to you all from here in London. If I could have my first slide visible, please. Okay, let me try sharing from here. Thank you. Thank you very much. Good evening to you here from London. If we move on to the next slide, what I'd like to do is start with a little bit about the context of the UK. We are a small island, but we are quite densely populated. So we have 66 million people living here in the UK, and our health service is a national health service, and it's free at the point of delivery. We have very strong primary care and very limited private healthcare, which means that the organisation of healthcare within the UK is almost entirely under government control. Next slide, please. If I summarise where we are, the UK has been hit hard. The UK has been hit very hard. Our first confirmed case in the UK was at the end of January. And by the end of February, we had the first evidence of transmission here in the UK. That's just 3 months ago. On the 23rd of March, we had an initial lockdown, which has now been eased. But if I present to you our data as of the 28th of May, you will see the scale of the challenge that we faced here in the UK. We have over 269,000 confirmed cases of coronavirus and over 37,000 confirmed coronavirus positive deaths. That gives a crude case fatality rate of around 14%. But I think actually the more important data is looking at the excess mortality. So comparing the mortality over the past few weeks with the mortality at the same period last year suggests that during the time of the coronavirus epidemic in the UK, over 60,000 people have died. The graphs at the bottom of the screen on the left look at total cases over time. And you can see that our total cases are continuing to rise. On the right, you see the daily death count. And this, at least, is now beginning to fall. But looking back at those numbers, we have a huge challenge here in the UK. Next slide, please. This is the local picture. So these are data from the hospital where I work and where I've been delivering coronavirus care. It's about 3 miles from where I'm sitting just now in the north of London, and it's called the Royal Free Hospital. We're looking at emergency medical admissions here. The green line is the total number. The red line are cases that were confirmed to be COVID positive, and the blue line are COVID negative emergency medical admissions. And I just want to use this to illustrate 2 points. The first of those points is that at its peak, we were seeing twice as many emergency admissions as we would normally expect to see in every 24-hour period. And of course, that puts a tremendous strain on resource and on our healthcare staff. But the second thing I just want you to note in passing is the blue line, the non-COVID emergency admissions. They reduced. And there's a real concern and emerging evidence that people who needed to be in hospital because of other medical problems, heart attack, stroke, cellulitis, pyelonephritis, whatever, were not coming to hospital, were scared to come to hospital. And thus the impact of coronavirus is not just on the direct admissions with COVID, but it's on delayed presentations of people with other medical problems. Next slide, please. There are some structures in the UK that make national responses easy. So we have a very rapid increase in critical care capacity. We had a 2,000 bed ICU opened here in London. It's actually a conference centre, or it was a conference centre. Fortunately, we didn't need all of that surge capacity, but that surge capacity was put in place by rapid central governmental planning under a command and control approach. The centralised nature of the National Health Service also means that the NHS is good at doing audit and research, and I'll share some data with those from you a little bit later on. But it was very much devolved to local hospitals about how they should plan for the pandemic and how they should deliver care. Next slide, please. And this slide tells us a little bit about what we did at the Royal Free. So we completely redesigned the way that doctors work in the hospital. A whole new rota system was developed such that all the junior staff from surgery, from ophthalmology, from gynecology were focused onto COVID care. And the senior staff who weren't able to do their normal ophthalmology clinics, for example, or colorectal operating, became part of the ITU team, essentially acting as ITU nurses and proning teams to increase the number of staff available in those resources. We've all had to work in incredibly different ways as we've dealt with this peak of admissions. We've also tried to be focused on staff well-being and education, and that's something that we might want to talk about too. It's really important. Next slide, please. Here are some challenges, and we don't have time to talk in detail about them all, but some of these may be the subject of questions a bit later on, and I'm happy to talk about any of these, but there have been some direct challenges around staff, so the provision of protective equipment, and actually staff feeling frightened that the protective equipment that they were given was not matching the pictures of protective equipment that people were using elsewhere around the world. So when I was on a COVID ward, I was wearing a surgical face mask, gloves, and a plastic apron. That's it. And that's very different from the provision that we've seen in other parts of the world. Staff testing was also a problem, and staff absence from work because they weren't able to access tests to know whether they were infectious or not, meant that the burden on the staff who were at work was even greater than it would have been otherwise. A real problem. I've already described critical care capacity, but the other problem that we ran into was oxygen capacity. The sheer number of people requiring oxygen as an inpatient and the flow of that oxygen, high flow oxygen, CPAP, meant that we were at, and for some hospitals, exceeded the capacity of the oxygen supply. It was freezing. The oxygen supply was at the limit of what was possible. Like everybody else around the world, we've been learning about this illness as we've gone forward, and that's produced some challenges in medical management. So for example, around thromboembolism, again, something we might come back to. The UK's had a particular problem around care homes. A huge number of the excess deaths have been in care homes, and how we manage vulnerable people living together with staff coming in and out of those homes has been a particular challenge. And I still don't think we've got that right. For me, one of the interesting things about this is that the coronavirus, the COVID aspect of things, in a way, has been the easier bit to manage. For me, as a pulmonologist anyway, what's been challenging has been the multimorbidity, because the people who've been admitted have been elderly with underlying medical problems. And we can treat the coronavirus with oxygen and respiratory support, but they need their diabetes managing, their heart failure managing, their kidney impairment managing. This is a very multimorbid population. I've hinted already about the problem of reduced number of acute presentations of other things that probably should have been in hospital, leading to late presentation. And we've also, of course, had to deal with the shutdown of routine services, working in different ways. So I've been doing my outpatient clinics with people with COPD by phone and by video link, for example, which just wasn't happening before routinely here in the UK. And finally, for those people who are surviving, we now have the challenge of rehabilitation. And whilst there's been a huge amount of organisation gone into the delivery of the acute response to COVID, I'm not seeing that same coordinated response to the rehabilitation and ongoing sequelae of people who have survived COVID. And we're just beginning to grapple with that now. Next slide, please. Highlight the role of the British Thoracic Society. So it's our equivalent of Respina, if you like. And the BTS has done a sterling job, actually, which has been reflected nationally. We're a small organisation, but has produced rapid guidelines, which have been well received and well respected within the UK. And there's clearly a role for a society, a respiratory society, to be leading that fight and leading that education and training and support of healthcare professionals wherever they may work. Next slide, please. I've hinted also about the centralised nature of our National Health Service being able to support audit and research. And these are data from ISARIC. So ISARIC was a sleeping research study that was able to be implemented at the time of a pandemic. It happened to be a coronavirus pandemic, but it could have been implemented in a new influenza pandemic too. And when this report was published in the British Medical Journal just a couple of weeks ago, it looked at over 20,000 hospital admissions in the UK, representing 34% of all our enormous number of UK hospital admissions. Some highlight figures. This is an elderly population. Their median age is in their 70s and a small preponderance of men, 60 to 40. The median time to symptom presentation, a few days. Median duration of hospital stay, about a week. About 1 in 5 people needing high dependency or intensive care, and lots of comorbidities, especially cardiac disease, diabetes, COPD, my own area of expertise, and chronic kidney disease. The hazard ratio for death plot at the bottom has a number of factors there, looking at different comorbidities, for example, but by far and away the strongest signal for the predictor of mortality in people admitted to hospital with COVID in the UK was age. The death rate in people in their 70s and 80s is really very high indeed. Next slide, please. Research is also possible in the National Health Service, and I highlight the recovery study. The recovery is a platform study. It tests different interventions, and as we have enough information about any one particular intervention, that intervention is stopped and another intervention is brought in. When I put these slides together last week, over 5,000 people have been recruited just here in the UK across 165 hospitals in just a month to this recovery study. It's been prioritized by the Chief Medical Officer, and only studies that have had that prioritization are allowed to proceed. So we can't just go off and do our own study of hydroxychloroquine or whatever it might be. Studies have to be badged nationally. And this study is a randomized control trial. It's looking at standard care versus standard care with a range of different things, including low-dose steroids, hydroxychloroquine, azithromycin, and results are just starting to emerge. But it's perhaps one of the advantages of having such a centralized health service that studies like this can get off the ground. Next slide, please. And so looking forward, we have two challenges. And I agree with Professor Morimura that we are also alert for the idea of a second wave. And wondering how to plan for that and what the magnitude of that is going to be. But in a way, we've been there before. At least we know what it looks like and will be better at managing it this time. And so perhaps the unmet need is addressing the long-term health consequences and the rehabilitation of the survivors from the first wave of coronavirus, many of whom are still in hospital, many of whom are very, very weak and in need of a lot of both physical and psychological rehabilitation too. And so for my final slide, I'd just like to say, next slide, please. In summary, the UK has been hit really, really hard. There are lots of things that have not gone well. A lot of things have not gone well. But some of the things that have gone well reflect the fact that we have a nationalized infrastructure which has permitted command and control, audit and research. And I'm proud of what the BTS has done in the same way that I know you will be proud of what Respina has achieved. Next slide, please. So I'm happy to answer any questions about that when we get to the questions and answers. I'm sorry that's been brief. I hope it gives you a flavor of what we've been doing here in the UK and how hard we've hit. I'm just going to end by thanking you all in Respina for the opportunity to share our learning, and I'm really enjoying hearing what everybody else has said as well. So thank you. It's back to the host from here in London. Thank you.
Thank you so much, Professor John Hertz. It's really interesting to hear from you, and I think we learned many things there. And I'm sure that participants will raise so many questions on this, because this is really a modeling of how a country with a good system in health also influenced by this pandemic very, very hard. The next will be Professor Fiona Lake from Australia. Professor Fiona Lake is a respiratory physician at the SCGH and lead the interstitial disease program. She is, yes.
Sorry, Prof.
After this,
Dr. Cesar is already there, already arrived, Prof.
Yeah, Professor Fiona Lake first, yeah, okay. So she is in the team for COVID-19 in Western Australia. So Professor Fiona Lake, please share your experience there.
Many thanks, and many thanks to Respina for inviting me. I will just get my program going, and you can hear me?
Yes.
Good. Okay, thank you. I'm very pleased to be able to join this webinar and to listen to all of the other groups, and I think we've had quite varied experiences with COVID. And the experience that we've had in Australia is quite different to the last one we just heard coming from the United Kingdom. In Australia, we're a very big island with a smallish population with a lot of space. And here, the summary, you can see our daily numbers, and really we have, as they say, not just flattened, but in some ways people talk about squashing the curve right down. At our peak, we didn't reach 500 per day, and fairly rapidly it's dropped down to very small numbers per day. And so if I summarize, the total number of cases we've had is about just over 7,000, with 100 deaths, and many people recovered. And indeed, I had the infamy, I guess, of looking after the first patient, sadly, who died, that was at the end of February. But if we look at what's happening now, this is a summary of what's happening around Australia at the moment. There are only 4 people in the intensive care unit anywhere in Australia, and there are only 23 people in hospital. And indeed, we have no people in hospital or ICU in Western Australia, which is where I come from. So what happened in Australia? And really we're in a position that initially we saw what was happening in China, and you didn't really think it was going to be affecting us, but gradually we watched it unfold in other countries. And so we were able to learn an awful lot and do a lot of planning. We had a lot of lead time. And here you can see the daily infection rate peaking in the kind of middle of to late March. Fairly early on, the focus in early March was on the borders, and as an island, the borders were quarantined. So that was anybody, people mainly flying in, or in people who came on cruise ships. And on March the 20th, the borders were closed. And then we had a series of lockdowns, and those lockdowns related to retail, so shops, people at work, avoiding travel. Anybody from overseas had 2 weeks quarantine set up in hotels. And then the borders across each state were closed, and then within each state. So in living in Western Australia, I couldn't travel out to the countryside or any holidays around the country. So what did the government focus on? These were the messages to the community: self-isolation, social distancing, recognising your symptoms and going and seeking help and getting tested, good personal hygiene with cough and hands, and also from a community point of view, recognising the big impact and helping out the elderly and vulnerable. And we have the COVID Safe app, which is meant to detect whether you've spent any time near somebody who's subsequently test positive for COVID. About 44% of the population have taken it up. It remains to be seen what kind of impact it will have. And then what else happened? And as I said, these are the things that the government focused on. Australian rules football is very popular here, and a very weird feeling of people playing a football game to an empty stadium. But retail shut down, work. People who were unemployed, there was significantly more monetary support for them, and also for homeless people, they were put up in hotels. But 2 of the big things were focusing on our borders and on our quarantine. So if we look at the cases that we have, 62% of the cases were acquired overseas. And so these were people who flew in or came in on boats. And so there was a lot of warning for that. And so they could be managed very easily and very well. Just over 27% were locally acquired, but it was very clear that where they got it from. And only 10% is the contact has not been identified. Where were the hotspots in Australia? As I mentioned, coming from returned travellers and cruise ships, but the kind of hotspots of the outbreakers were, as other people have noted, aged care facilities where people are elderly and so very vulnerable with quite a high death rate. Outbreak in meat works, possibly related to a lot of the water and the kind of aerosolation that's used. In a few healthcare facilities where healthcare workers tend to put up with their symptoms and go along to work, and in one in northern Tasmania, it resulted in 5,000 people being put in isolation. The testing has gradually ramped up, initially focused on those that had symptoms, but now there's much more widespread testing at workplace, in hospitality industry and healthcare workers. We have very little of the rapid testing, which we're trying to choose to use, in particular in rural areas where otherwise they don't have testing. They have to fly it down by plane. It'll take about 3 days to get the results. So if we think about the impact of COVID, the impact is on the individual, obviously, who gets infected. There's a mental health impact on the community as well as those that get infected, a big impact on your health services, and obviously an impact on the community. And the unemployment rate is significantly greater, and clearly the things like recessions are going to be an issue. I just wanted to talk about the health service because we did have some lead time, and initially we could see what was happening elsewhere, and there was an enormous amount of planning. Management guides, which we kept learning from all of you, people who are looking after a lot of people, developing guides, and they were useful for smaller centres who were going to look after people but needed that extra support. But also they were useful for general agreements, such as we would not give any treatment for COVID unless it was proven, but we would aim to enter people into randomised controlled trials, and those trials were ensure that they were substantial enough to get some answers. Unfortunately, a lot of those trials haven't really happened because of the trickle of cases. Also, the planning to do with resources and staffing, and we've been extremely lucky with PPE, very carefully not overusing it. But on my the health department website, I have every day, I can see how many gloves there are, how many masks there are, and can see ahead what's happening in the future. We've had to change our services for a lot. Elective surgery was cancelled, but it got started again this week. We've had to set up in the hospital a different patient flow. So I'm part of the COVID assessment team, anybody with a fever that's unexplained, so that we were able to provide safe care and safe, so we don't allow the hospital to have cases of unsuspected COVID in the hospital. Outpatients has moved in particular to telehealth and video health. But some other things have changed, and people mentioned concern that some people might not be coming along to have their, there may be delays in the diagnosis of cancers or whatever. But here in Perth, we have had no influenza for 5 weeks, which is unbelievable. It has just not happened before. So maybe a cure for influenza is actually COVID. What about individuals? There's big impact on individuals, obviously fear. I looked after the first 2 patients, and every time they turned on the television, all they could see was themselves getting out of planes and being told this is a deadly disease. So it does affect patients. It does affect healthcare workers and the community. For individual patients, there was a real focus on making sure we understood what was important to them and what were their goals of care. And the trouble is with COVID, you've got to have it under a very rapid, short period of time. And so that stressed a lot of patients out. And we do have a concern about a negative impact on usual patient care. So some departments reluctant to do investigations or do their usual treatment for people until the COVID results are through and a negative, which they are at the moment. But there is a concern that we're negatively impacting patients' care. For example, giving BiPAP for patients with COPD and type 2 failure. But the other thing we should think about is actually COVID is a real opportunity. And in fact, we're having a talk next week that coronavirus is the innovation enabler. So things that we've tried to do for ages have actually happened rapidly. This includes alternate pathways of care, and for many, in fact, telehealth or home-based care is an advance on what we do now. And I guess patients also have realised perhaps we don't need to be seeing some of our patients as often as we do. Much greater engagement and communication in our settings with the development of guidelines, pathways, resources, multidisciplinary meetings. So we're actually talking to each other much better and understanding patients. And as I said, changes in services, buildings have gone up rapidly, changes have been brought about. What we're doing right now is a change from what we would have done in the past. So in summary, Australia has missed a crisis so far. The health service through to community interactions have changed forever in our society. Some things we'll go back to, but many things we will not go back to. But even missing a crisis has been very costly, both emotionally and from a financial point of view in the economy and also in the health services. And our challenge right now is how can we ensure a safe care, but in a sustainable way into the future? Thanks very much.
Thank you, Prof. Fiona. Interesting. And I'm sure that we have to learn from you there, because Australia, I think we haven't heard about something that is very hard situation. Yeah, it's quite like normal, not so high in mortality. So it's interesting. Dear participants, we have to have a break, a slight break, because there is an information from the host. And please, host, I give you time for the information that you will provide to the participant.
Thank you, Prof. Menaldi. To all participants, please fill in the post-test after this webinar for the requirement to get the certificate. There will be a following link, like stated in the screen, and the post-test will be open for 30 minutes after the webinar is finished. To all the participants, please fill the post-test after this webinar for the requirement to get a certificate using the following link that will be on the chat, on the Zoom, and also chat in the YouTube. And the post-test will be open for 30 minutes after the webinar is finished. Thank you.
Thank you, Dr.
Menaldi.
Yeah, welcome. So this is a very important information, because all the participants will get the certificate, the e-certificate, right? Now we have with us Professor Cesare Gregoretti from Italy. Professor Cesare Gregoretti is my close friend for a long time in Respina. He is a professor of intensive care and anesthesiology at University Turin and Novara, Italy. And he is also a director of General ICU and Anesthesiology Service, Orthopedic and Trauma Center at Turin, Italy. Professor Cesare Gregoretti, the time is yours, please.
Thank you, Rasmini. Menaldi, can you hear me? Hello?
Yes, Professor, I can hear you clearly.
Yes, just time passed by. I'm not longer in Turin. I moved to Palermo in the south of Italy a few years ago. I'm now in Cefalù, that is close to Palermo. I have a university position for directing a university ICU. Anyway, I just want to try to share my screen. Okay, let me try with that. Does it work? Okay, let me see. Okay. Can you see my presentation?
Yes, very clear.
Okay, very clear. Okay, wait, just. And the slides are clear. Okay, So everybody knows that we have bit very hard in Italy with more than 30,000 deaths. And here in Sicily, the situation was positive patient was quite low, and also the number of the patient admitted in the ICU was low. But I was following up the colleague of mine, and they were still working in Turin, where in our region more than 30,000 people died. So I just wanted to give you a short feedback on what in Turin my colleague did using helmet CPAP in a step down unit, using a new invention, I would say, because it's our patent, that allowed us to use a helmet CPAP with tidal volume measurement. So the patients were in a step down unit, and they were very closely followed up. So I go on. Okay, let me see if I go on with my slides. Okay, I don't, okay. So CPAP via helmet compared to face mask may reduce aerosolization of the secretion to the environment and operators, increasing safety during viral respiratory infection outbreak. And this was demonstrated by WHO in just a few years ago. As you know, in China, they had a lot of problems a few years ago because of aerosolization using non-invasive ventilation in the so-called intentional leak system. So we also know the accurate measurement of tidal volume is very clinically important in hypoxemic respiratory disease, but maybe as most of you know, reliable monitor of tidal volume during helmet CPAP was not so possible right now, but we recently published the possibility to do this, and we published this article in the Blue Journal a few days ago. So far, there is no any actual clinical prospective study in acute hypoxemic respiratory failure undergoing helmet CPAP and tidal volume monitoring. So we enrolled during the COVID outbreak in Piedmont region, thousands of patients, but just 35 patients were followed up using helmet ventilation and monitoring tidal volume. And all the patients were positive for bilateral interstitial pneumonia at a CT scan. And so far, 33 patients were already followed up. And all the patients that underwent helmet CPAP all around the clock via a turbine-driven ventilator in intentional leak single configuration, equipped with a dedicated new software to estimate the tidal volume. This is the helmet that we used. This is intentional leak. The leaks was filtered with an antiviral filter. Okay, and we had another antiviral filter on the inlet. So I mean, the environment was almost completely sealed and closed, so there were no contamination for the operator. And on the right side, you can see, because we did it, all one of the patients that was switching from the supine to prone position, because in the protocol was allowed to operators to prone the patient for at least 6 hours a day for 2 consecutive hours, 3 times a day. So there is the population, this is the age, most of the patients were male, as everybody know, and they are the comorbidity on admission, Malignancy were present in 7 patients, and chronic renal disease also in 7 patients, hypertension in 23 patients. But very interestingly, as you will see at the beginning of the presentation, the differences in terms of comorbidities between survivors and not survivors were not very high indeed. So this is the medication. We use methylprednisolone from the very beginning, 1 milligram per kilo in a 26 patient, and then we use other drugs that all the audience know very well, and also in 22 patients we use low molecular heparin. So on the admission, the PO2 ratio was very, very low. The average was 131 plus or minus 48. Patients have a high respiratory rates, low PCO2, and almost not, but very high Borg-Stale dyspnea score. Interestingly, even it's difficult to compare Venturi mask to helmet CPAP because the FiO2 is much more constant due to helmet CPAP. The PO2, FiO2 increased, but interestingly, respiratory rates and decreased, PCO2 increased too, Borg decreased, and this all was obtained with an average PAPE of about 12, with deviation standard of about 2. And very interestingly, the tidal volume of all enrolled patients was quite small, because you know, high tidal volume usually are coupled with high level of transpulmonary pressure, and high transpulmonary pressure is linked to the so-called self-inflicted lung injury. But the interesting data also comes from the patients who were able to be weaned from helmet CPAP and people that were intubated. When the patients were weaned for helmet CPAP, they had a very significantly higher PO2 ratio compared to the patients who were intubated. The PO2 was not significantly different. The respiratory rate was significantly different, 28 against 18. The Borg scale was significantly different too, and also the level of CPAP. But more interestingly, even as you can see, the tidal volume was not significantly different, because 342 is not very significantly different from 400, but the minute ventilation, the ventilatory alveolar ventilation was much more different between the two groups, indicating a possible increased dead space in the patient who did not benefit of helmet CPAP. So what's the data about the survivor and not survivor? Again, you can see the tidal volume was not significantly different. It was a bit different in alveolar ventilation between the two categories. Respiratory rates, was not so significantly different, but the PO2 FiO2 ratio was different between survivor and not survivor. So we also tried, even we have no time already to do any statistically analysis, but you can see the population was just a bit younger, and we have also some differences in terms of gender, and we have differences in terms of people who had some other comorbidities and chronic renal failure just a bit higher, and COPD, for example. So this is a result of patients that were put prone. We have some data already coming from JAMA, from the group of Milan. Okay, and you can see all the patients who survived and were put prone have a significant increase of PO2 ratio when they were switching from the supine to the prone position. But the person that was not able to improve arterial blood gases unfortunately died. So prone position was benefit in patients who survived. At the follow-up, we have the follow-up of 33 patients. The survivors were 24 out of 33, but with that 5 of these patients were do not intubate. The interesting data that came from this analysis that the overall mortality rate was quite low. It is quite similar to the other mortality rate that was shown for the patient who were intubated in ICU. So the interesting message is our population, even it was strictly followed up in a semi-intensive step-down unit, it was not intubated. The mortality rate was not significantly different for the patient who were intubated. That means that potentially we have a tool, okay, to avoid intubation and give maybe some more possibility for the new wave because the mortality was not higher than the group that were intubated. So our conclusion is that helmet CPAP significantly improve arterial blood gas, respiratory rates, and other parameters, compared to Venturi mask. No survivor showed a low PO2 ratio within 6 hours after CPAP helmet initiation. No survivor showed, were older, that is a mistake, more hypertension, chronic and cardiovascular renal disease, and COPD. Mean time of the beginning of system and hospital admission was not different between survivor and not survivor. So time on helmet CPAP was 9 days, plus or minus 4, and time on helmet CPAP all around the clocks, that means 24 hours a day, was 4 days. Interruption, okay, even switching from the supine to prone position. This is important data. 15 patients were put prone, as I already told you. A overall mortality rate without DNI was 22.44%. Thank you very much for your attention.
Thank you so much, Professor Cesare. So don't go away, please stay with us here. And Professor Cesare already offered us an innovative, some innovative thing and new equipments. And I think we have to try it because this is really important as one of the other alternative for the oxygen modality therapy. Okay, now we have to move to Singapore. From Italy to Singapore, there Dr. Puah Serhon already prepared. Dr. Puah is a consultant of respiratory physician and intensivist at the Department of Respiratory and Critical Care Medicine at Tan Tock Seng Hospital, Singapore. Dr. Puah, please.
Hello, hi everybody. First of all, I'd like to thank Respina for this wonderful opportunity to actually listen to all our distinguished speakers and this given time to share the situation in Singapore. And first of all, I've got nothing to disclose for this talk. So we first saw our first patient on the 23rd of January 2020, and we were watching the situation in China quite closely, just like every country that has been presented so far. Now, as you can see at the beginning of the outbreak, the numbers were actually creeping up quite slowly. Then all of a sudden in April, the numbers just started shooting up. We were wondering why, and what has actually happened is that I'd like to share that one of the important group of workers who are currently building and monitoring and maintaining the country are our blue-collar foreign workers. And these foreign workers are a close-knit community, and they live in dorms with other workers as well. So interestingly, because it is so easily spreadable, once one of the workers actually catches the virus, it was like wildfire. So once one or two of a cluster started popping up among the dormitories, the government started acting quite rapidly to start isolating all the dorm workers into their own dorms, and also proactively swabbing all of them. And then the numbers started to increase, and we admitted them and isolated them in the hospitals quite quickly. So as you can see, what has happened in Singapore is that the yellow bars represent the dorm workers, and they have been rising since April. But if you look at the blue bars, which are actually the community cases between the residents itself, it's actually come down and plateaued. So what we have decided to do is that because the dorm workers were a different cohort altogether, because most of them, the big majority of them, were actually young and relatively fit. So we've decided to divide the numbers as such. So as you can see, the community cases are in the blue bars again, and they're actually coming down and has nicely flattened out. The dorm residents in April also started climbing up, as you can see. This is where we started detecting them. And then, if you can see, the numbers have started to plateau and started to come down. There's another group of blue-collar workers who are work permit holders who do not stay in dorms, and we are also actively swabbing them. As you can see, the numbers are also coming down. One of the things that the government has done is that they have started building community isolation facilities, and that's where they started housing well-positive patients. Because as the numbers started to go up, the policy of the government is actually to admit all patients who are positive within a medical facility. And because the numbers, we couldn't really cope with it, so all these facilities started popping up, and we started housing well patients over there. And we were keeping them there until they were asymptomatic and they were swab negative. So there were different levels in Singapore. And during peacetime, it's what we call it, the level is green. But since December up to January, we started becoming yellow, where what the color means is actually the steps that the government have taken to actually monitor the disease and the steps to prevent the disease within the community itself. Now, we started hitting orange quite early on in February. The first week of February, we've turned orange. And what that means is that there's a lot of isolation happening. We were monitoring temperatures as we go in and out of facilities. And also, there was a lot of isolation between families and patients. So subsequently after that, sometime in April, because of the rise in numbers, the circuit breaker was introduced. That's when the country went into total lockdown, where even families and the community can't even leave their household without a mask, and they have to actually check in and out as they go into supermarkets to buy their groceries. So we are currently still in the lockdown, but at the end of the talk, I'll share what are the steps next the government has taken to open up this lockdown. The country is quite small, so we have total 8 government hospitals in the whole country. This is not including some of the private hospitals, but most of the patients who are suffering from the coronavirus is actually being housed within the government hospitals itself. The main center that is dealing with the coronavirus is the National Center for Infectious Diseases. Now, it is actually linked to the hospital that I'm working in, Tan Tock Seng Hospital, and we just crossed the bridge and we are there. We are basically neighbors. Now, the NCID on normal times actually have a bed capacity of 330 beds, but this has been expanded to 586 beds. They have a dedicated ICU just to deal with infectious disease cases, and that could have been that could have ramped up to 38 beds. But now we were preparing for the surge, so we were in combination with Tan Tock Seng, and we have prepared 188 beds for a surge, and even had plans to move up to 288 beds. The whole country were prepared to ventilate 600 patients in their ICUs. So what is the current state? And these numbers were published as of yesterday. And the total numbers that we have were 33,860 cases. 58% of these numbers have been discharged well, and 40.6% of these numbers are still in isolation. 1.4% of them are still admitted in a hospital and not in an isolation facility. Now, since the outbreak started, we have seen 113 patients that required invasive mechanical ventilation. And that is at the 0.33% of intubation rate. The denominator now can be argued and that can be discussed. We do not know what's the actual proper denominator here, but we take total positive cases as of yesterday, and that's how we came to the 0.33% intubation rate. We had 23 deaths so far, out of which 14 actually passed away in ICU and 9 outside of ICU. And that makes our mortality rate look interestingly low at 0.068%. Those that received invasive mechanical ventilation had a mortality rate of 12.4%. Now I'm going to shift gears into the ICU now and just share some of our experiences and some of the data that we are seeing. We have collected 102 ever intubated patients, and we are analyzing the data as at this juncture. And what we have found is very similar to what published data is currently available, and that most of the patients that come into the ICU requiring invasive mechanical ventilation are older. So most of them are 60 years old and above, and they are all predominantly male. The mean Apache score is about 16.2, and the mean SOFA score is at 5. Now, our mean compliance rate is at 37.9. So this is quite an interesting finding because we have published data from Professor Luciano Gattinoni and also from Professor John Marini, where they talked about the L and H phenotype. And I think they described a population that required invasive mechanical ventilation, that about 60% of the patients actually had good lung compliance. We're seeing the other end of the aspect though, at 60% having poor compliance at the onset of ventilation. We did early on an interim analysis for 10 intubated ICU patients versus 50 confirmed patients. And we found, just like most studies have shown, that the patients who required invasive mechanical ventilation had higher neutrophil counts. They were more lymphopenic. They had a raised lactate dehydrogenase scores. The neutrophil lymphocyte ratio, LDH and lymphocyte ratios were higher. And interestingly, they had a cutoff of a raised CA8 that predicts that the patients will require invasive mechanical ventilation. And this is, of course, not surprising that all patients that receive invasive mechanical ventilation had chest X-ray infiltrates. So our practices have been changing, and this has been one of the most interesting things that have come about. And we noticed from the early onset when we started ventilating patients, when we proned them, their oxygen saturation actually improved quite dramatically. And we started moving prone ventilation into the general wards. And this was a nice case series that was published by my colleague, Dr. Ng et al. And it was recently published in the ERJ. And she described a case series of 10 patients that were prone in the general wards. And what they did was that they actually selected patients who required nasal cannula oxygenation at the minimum. And this was for various reasons, whether they were hypoxemic at rest, or whether they had oxygen desaturation during ambulation, or they were just have an increased work of breathing. And the prescription was made to prone them on their bellies 5 times a day, and each episode lasting at least 1 hour longer if they are able to tolerate it. And if they cannot tolerate prone ventilation, they actually tried it to stay on their lateral positions, either the left or the right. And this started happening roughly on day 13 of their illness. And the cumulative hours of prone was about 27 hours. So in that case series of 10 patients, only 1 ended up being intubated and unfortunately passed away. And the highest oxygen escalation was up to a high flow nasal cannula for these patients. And the rest actually recovered, and most of them have been discharged. What have we observed so far is that, especially at the beginning of the admission into ICU, most of the time the radiological changes do not match with the degree of hypoxemia. At the beginning of intubation, the driving pressures and the plateau pressures tend to be low despite the high FiO2 requirements and PEEP. Now, prone really works in our experience, and we find that when they're severely hypoxemic, if you prone them, the oxygen saturation tend to improve quite nicely. Another interesting thing that we found is that some patients actually develop autodeoxia after extubation, or actually midway through their intubations, midway through their stay in the ICU. And some of them actually do desaturate when you sit them up, but when you lie them down supine, they actually get better. So this phenomenon has been it's noticed, and we actually share it with some of our physiotherapists, because a lot of this will hamper rehabilitation and physiotherapy as they start to recover. There's a lot of fear to move them because they do desaturate quite markedly. And out of the 102 patients that we are seeing, 9 patients ended up with a tracheostomy, and 30 of them actually had required dialysis. And what we have found is that most of the patients that actually develop acute kidney injury or require any form of dialysis actually end up being non-survivors. So how is Singapore getting out of this? Because the numbers in the community have flattened out quite nicely and the numbers were low 5 on averages, we are starting to come out of the circuit breaker, which was introduced early in April. And next week, we are starting with the first phase where they call it safe opening. So during the circuit breaker, children could not go to school, but now we are starting to release them one by one in stages, and they are monitoring the situation quite closely. If the numbers do not go up, then phase 2 will start opening, and some businesses will start opening, and some retail shops will start opening. And the aim and the hope is to actually end in phase 3, where we open up a safe nation. But of course, all of us are keeping a close eye on a second wave as well, just like all other countries. With that, I end my presentation, and I'm happy to take any questions at the end of this. And again, once again, thank you very much for this opportunity.
Thank you so much, Dr. Puah. We are near in countries, so I think your success will be also my success.
Sure.
The next is the last speaker, is Professor Venu Gopal Reddy. He is my brother from the United States of America. He is the professor of anesthesiology and critical care medicine, director of mortality and morbidity, Department of Anesthesiology, Perioperative Medicine and Critical Care Medicine, Penn State College of Medicine, Penn State University, Hershey, USA. He already joined Respina from the second of Respina, so now he is also with us. We are very happy. We are very glad to have him again with us now. Thank you, Professor Reddy. And now we have to spare our concentration because this will be a nice presentation from Dr. Gopal Reddy, who is really experienced in Respina. Please, Dr. Reddy.
Good morning from the USA, but probably good evening to the Indonesian and my colleagues and my brother Menaldi. I hope you can hear me. As I come from United States, I live in a state called Pennsylvania. Hershey is where I work in a medical college and a university called Penn State University. USA experienced its first case of coronavirus in the month of January 19th, when a 35-year-old man presented with a 4-day cough and fever in Washington, Seattle. He had returned from a family visit in Wuhan, China, and the very next day, the CDC confirmed through a nasopharyngeal testing that he was positive for a transcriptase polymerase chain reaction. Interestingly, he was the first patient in USA to get remdesivir. Fortunately, the patient survived. As of today, United States has probably the highest number of cases, nearing 1.8 million cases in the whole of USA. Please do not forget that USA population is about 330 million, so that might also explain a very high number of cases, and also the number of tests that has been done per million is also quite high. Just 2 days ago, USA crossed deaths of more than 100,000. It's sad, but things seems to be moving in the right direction. I come from Pennsylvania state, which has about 75,000 cases in my own state, with death reaching about 5,500. My neighboring state is New York, which has 377,000 with death reaching nearly 30,000. If you look at the Indonesian curve, you'll realize that the number of cases in Indonesia as of today is about 25 or 26,000. Just compare that to New York itself, where the death is nearly 30,000. So yes, USA has a very big number of cases, and unfortunately, that number of cases also comes with mortality. So fortunately, just 2 days ago, the USA, the data is released in terms of the healthcare professionals who have been affected by COVID-19. The data was collected from nearly 1.4 million population who had proven positive to COVID, but the data was available only for about 300,000 patients. Among them, among 300,000 patients, nearly 64,000 cases were among healthcare personnel. You can imagine the amount of exposure a healthcare professional has been with COVID-19. So the data we have as of today, the data is still ongoing. As of today, among 36,000 healthcare professionals where we have a data, 307 healthcare professionals have died. That roughly translates into about, for every 10,000, you're losing, sorry, for every 1,000, you lose one patient. So recently, just a couple of, last month, the first paper from New York came with about 5,000 cases that were admitted to the hospital. And unfortunately, USA has fairly nearly 30%, depending on where you come from, like Pennsylvania and New York, has a problem with obesity. Most people are obese. And among the 5,700 cases in New York, males predominated like any other country. Hypertension, diabetes, and renal injury, impairment, or renal disease were co-factors which were commonly seen among COVID patients. But I would like you to look at the obesity. Nearly 41% of these obese people are at a higher risk of developing a COVID just because of their weight. Now, if you look at the study is still ongoing, so the results are not complete. If you look at those number of patients, about 5,700, nearly 1,200 to 1,300 required admission to ICU, and majority of them had a mechanical ventilation. Nearly 1/4 of those patients went into acute kidney injury, but did not mean that they would require a renal replacement therapy, but about 3.9% of the acute kidney injury ended up requiring some sort of renal replacement therapy. Now, there were a review of the patients of 2,634 patients were reviewed at the time of discharge or died, and nearly 553 patients had died. That's roughly about 21% of admission to ICU. Please remember that the patients still are in the hospital are about 3,000 patients. I would like you to look into a different scenario, having experienced, exposed, looked into the COVID-19 in the United States from the month of February, March, April, May, roughly exactly 4 months as of today. What have we learned from COVID? What did we do better, or what are we doing to improve ourselves in order to minimize morbidity and mortality? In the next few of my slides, you will see what changes some of the hospitals have done. I should also let you know that every hospital in USA does not follow the same standard protocol. Unfortunately, there is not a single protocol for the whole country when it comes to management, but when it comes to prevention, yes, the protocol remains more or less same everywhere. But individual cities, individual hospitals have slightly modified how they manage their patients in the intensive care unit, just because of the sheer number of cases that were admitted. Now let me go step by step. The most common things that we see. In the past, a couple of months ago, when we found somebody being hypoxic on 4 to 6 or 8 liters of oxygen, and his saturation is about 55%, and he has some signs of respiratory disease, distress, minimal changes on chest X-ray, he would be concerned or considered for an urgent emergent intubation and mechanical ventilation because of the fear of hypoxia. But of late, we also learned there is something called silent hypoxia, where patients are walking with a saturation of 45, 50, 52%. There's also papers talking about the mystery of so-called happy hypoxia, wandering hypoxia, hypoxia arrival. You read all these on literature. So now we have realized that just because somebody is hypoxic does not mean they need intubation. We go forward considering by increase the oxygen saturation to above 88% by either high flow nasal cannula or nasal cannula. We also have learned that awake early proning is extremely useful in increasing the oxygen saturation. And we let our patients lie in prone as long as possible, because we have noticed that sometimes when they turn supine, the saturation drops again. So proning in supine to early in awake patient has changed dramatically in many of these patients. We also look for increased worker breathing, and we look for increased PaCO2 or an increased FiO2 requirement, which might suggest intubation. We also felt in the past, every patient in respiratory failure secondary to COVID means ARDS. The literature coming from UK, USA, and Italy seems that there is something else called CARDS, which means corona-associated ARDS. So, in the past, we treated every patient who was on mechanical ventilation equals ARDS net protocol. But we also found some patients, when they intubated, and I just heard from my colleagues from Singapore, that some of these patients really did not behave like ARDS, meaning for a small pressure, you were able to achieve the same tidal volume, where the lung compliance was quite good, but recruitability was not there. And chest X-ray did not typically show an ARDS picture like bilateral infiltrates or pulmonary edema. So we learned hypoxia could be because of a dysregulation in pulmonary perfusion, considering pulmonary microthrombi and a typical ARDS. Now we understand that hypoxia is not just because of ARDS. So we also looked at hypoxia and what is the probability of these patients becoming hypoxic. We looked at the dysregulation of pulmonary circulation, or patients in a typical ARDS picture, or patients who have a pulmonary microthrombi. Literature is now considering and talking about 2 kinds of phenotype, phenotype L, which does not behave like ARDS, and phenotype H, with all the signs and symptoms of a classical ARDS. We also learned that in the past, when I had treated patients with pneumonia or patients with septic shock ending up with ARDS, we were not that much worried about central nervous system. We all agree on that. But today, COVID can manifest a CNS manifestation is also very likely possible with CNS symptoms like ischemic stroke, cerebral hemorrhage, impaired consciousness, and sudden unexplained cardiac arrest. Everybody, if they have worked in the COVID unit, would have come looked into one of these at some time. So neurological manifestation has to be looked into in these patients. We all treated pneumonias in ARDS, and very, very unfrequently, we had concerns about cardiac injury. But COVID works differently. Acute cardiac injury is seen in nearly 7 to 12% of COVID patients. Or maybe the mechanism which has been explained in many literature, we are concerned about. Whenever we have a persistent hypotension, despite being on various vasopressor medication, we always look for a cardiac issue, like getting a troponins checked, getting an echocardiography, and ruling out a cardiac pathology. Middle age, men, patients with hypertension and diabetes are at higher risk. We are doing a bit more laboratory work for COVID patients compared to a standard H1N1 influenza or a viral pneumonia or a bacterial pneumonia, because we have learned that D-dimer, like dominant factor, increases in more than 50% of patients. If you trace the D-dimer over a period of time, it could actually tell you whether the patient is going to make it or not make it. It also indicates a D-dimer which is high at the time of admission means increased ICU admission, increased mortality. In addition to D-dimer, we also look at thrombocytopenia, LDH, ferritin, C-reactive protein, IL-6. An increase in any one of these suggests worse outcome. So now we have markers for COVID-19, which might not be beneficial if these numbers keeps climbing. Increase in troponin by day 4 is not a good sign because your cardiac muscle has involved now. As I mentioned to you, intubate every COVID patient is not the rule anymore. Every hospital has their own protocol, how to admit, what to do, how to segregate, ICU admission, what protocols, what laboratory works. Even in my own hospital, we have many protocols. Simple rule, protocol for intubation includes putting these patients on high flow nasal cannula and checking the blood gases, putting on prone positioning, awake prone positioning, and if the PaO to FiO2 ratio is less than 150 millimeters of mercury, lasting for 2 hours, plus increased worker breathing, then we would consider intubation now, not before. Standard mechanical ventilation graphs you can find anywhere, but we divide them into 2 kinds. If the patient has a better compliance, meaning that for a given driving pressure, he can ventilate better with increased tidal volume, then we do not change the tidal volume. But if the driving pressure, there's the pressure difference between plateau pressure minus P is more than 15 centimeters of water, we treat them like ARDS patients. The rest of the protocol, the rest of the management does not differ much from ARDS. Consideration of using neuromuscular blocking drugs, consideration of turning the patient prone, intubated and prone, and leaving them for 14 to 16 hours, aiming for a saturation and minimizing the plateau pressure, standard protocol that would be applied to any patients with ARDS or non-ARDS. What about renal replacement therapy? In the past, I'm sure colleagues who are listening to me will agree with me that CRRT does not mean anticoagulation. We all know that we don't anticoagulate all our patients who are on CRRT. But then we started seeing clotting, blockage of the circuits. Then we started putting them on heparin. Now, aggressive anticoagulation is quite normal. There are a couple of papers from Ireland, a paper from USA recommending aggressive anticoagulation. We use D-dimer. Again, I must say D-dimer numbers varies from hospital to hospital. Some say if it's more than 2 micrograms per ml, some say if it's more than 1 microgram per ml, plus CRRT equals full anticoagulation. A D-dimer level of more than 2 max per ml means start them on full anticoagulation, either enoxaparin, some people say 0.5, some say 1 milligram per kg per day, or heparin infusion targeting APTT level of 55 to 75 seconds. Consider this to H1N1 or Middle Eastern respiratory distress syndrome or a standard bacterial pneumonia. How many times have you asked a question, does my patient require full anticoagulation? That number was very, very small, but not with COVID. There's a very good paper looking at the development of thrombi trigger group, which showed that lots of patients, up to 16%, had pulmonary embolism, or if they are on CRRT, look at numbers, nearly every patient except 1 or 2 had a clotting mechanism. So these are the patients who, despite anticoagulation, may still develop clotting. So in such cases, suggestion is to increase the APTT to around 100 seconds. Extubation, one has to be extremely careful. Do not forget that you're extubating a COVID patient. Consider antiemetics to minimize coughing and vomiting. Despot with lidocaine infusion or Precedex infusion to minimize coughing. And never look at the face when you are extubating the patient. There are many, many people that come up, many suggestions. We use the standard face mask, covers the patient, and gently pull the endotracheal tube over a face mask. Many medications have been used, and this has been, our hospital has entered into a randomized controlled trial among other hospitals to utilize remdesivir. On day 1, we give 200 milligrams infusion over 1 hour, followed by 100 milligrams infusion over 30 minutes. And a couple of our patients, the data is still there. We are still into a part of the study, though I'm unable to talk about the data. So I would leave this at this thing about that. In the past, it was not uncommon to use hydroxychloroquine and azithromycin. Then we realized that we have cardiac arrhythmias, prolongation of the QT interval, and there were cardiac arrest. And a study showed, looking at retrospectively, it did not do any benefit, but did more harm. So as a result of it, we, in our hospital, we do not use hydroxychloroquine either alone or in combination with azithromycin. What about, this is my last slide, what about convalescent plasma? A good paper appeared from Houston, Texas, looking at 25 patients who received convalescent plasma therapy, and results were very encouraging. So many hospitals use convalescent plasma therapy, and their result seems to be encouraging. In some places, not so. There are a couple of randomized control trials are in progress. And in New York, I understand that they are using IL-6 antibodies, and they seem to be doing very well. In my hospital, we have used only for 1 patient, and I cannot disclose the outcome, but that is not something which we are using regularly. At this point, I would stop my talk, and thank you, Menaldi, for giving me an opportunity to be a part of your group once again. And you know, I've been with you for more than 20 or 21 years. Thank you very much.
Thank you so much, Professor Dr. Gopal Reddy. It is really nice, and I'm sure I already read so many questions about this. And please, to all participants, don't go away. Please stay here. We still have an interesting session. It will be a QA session. But before the QA session, that I will ask Dr. Vinci for the first, and then Dr. Dian to read the question. Host, do you want to again explain about how to get the certificate?
Yes, Prof. Uh, we would like to remind all the participants to, after the webinar, to fill in and submit the post-test for the electronic certificate with the following link, and the post-test will be open for 30 minutes after the webinar is finished. Thank you, Prof.
And for Dr. Vinci, since there is a trouble in connection with him, all the question will be asked from host.
Okay, so Dr. Vinci is not there. So please read the questions, all questions raised to Professor Morimura. And Professor Morimura, please prepare to answer all the questions that is going to you. Please.
Okay, thank you. So I have already replied to the question. Okay,
Yes.
so yes,
Thank you very much.
one is how to triage at ER. Okay, so could you hear me? Because
yes, sure.
That's so good. Yes, sorry. Okay, so how can we triage in the ER? So we have different ways compared with United States or United Kingdom and European other countries, and our pre-hospital regulation based on the medical control protocol. It's we have a lot of protocol to determine the level of emergency medical facilities. We have 3 different type of emergency hospital and emergency department. So tertiary and secondary and primary. So and then patient come to us via ambulance or walking. We have triage in front in the hospital, and we have already prepared the room, especially for room for COVID patients and COVID area. Maybe most of hospitals response is in the same manner. So and then we triage by patient history, compliant, and vital sign by themselves. And so in addition, the ambulance crew information, we decide to the severity and acuity and the suitable room to treat. All procedure is based on the protocol. This is the answer for the first question. And the second question is how to detect the second wave. It is very, very difficult question. However, we will try to detect the second wave via the little bit differences between the previous data and in addition to the other parameters. Okay. Okay, so I will try. I will add my answer for other questions from now. Thanks.
Okay, thank you, Prof. Morimura. Dr. Dian, do you already collect the question to Professor John Hurst? Will you read it for him?
So I've also been, thank you. I've also been trying to answer the questions as they've been coming through on the webinar. Interestingly, there are some themes that come through, and I can see that there's a lot of interest in the different therapies that people have been using. So remdesivir has come up. There's been a few questions about hydroxychloroquine, of course, azithromycin. And what I would say that here in the UK, those are only really being used in the context of clinical trials. The hydroxychloroquine one is particularly interesting because colleagues will have seen the decision from the WHO not to recommend hydroxychloroquine. There's a big randomized control trial going on right now in the UK of hydroxychloroquine. And just last week, the decision was made to continue that study because we do want to have a definitive answer from a randomized control trial so that we're not having to rely on retrospective evidence. The second one, just to mention, because it's something that I feel passionately about, is the question came up about what components of rehabilitation might be necessary. And I'd just like to emphasize, I think, the importance of that, to not forget the survivors of this devastating infection, and encouraging those people to get back to full health, to work, to society is so important. And we don't really know what the components of rehab are going to be, but they're going to need to be holistic. They're going to need to be physical, and they're going to need to be psychological, and they're going to be about identifying people who may have developed long-term complications from COVID. So pulmonary fibrosis, as an example, if the same thing is going to happen with coronavirus as happened with SARS and with MERS. So those are a couple of themes that I picked out when I'm coming. If there are any additional questions, happy to answer those or to join the discussion as we go forward. So thank you, Professor Manaldi Rasman.
Thank you, Prof. Hertz. Now I also get a message from Dr. Shogi in London that he also noted some question. Please, Dr. Ogi, you can read the question from the participant, and yeah, it's your time.
Hello, thank you, Professor. All right. Hi, all. My name is Shogi, and I'm also one of the committee in the Respina, and I'm live from London, also from and now I have a certain questions that also thrown by our participant in YouTube to Professor John. Maybe you can answer about these questions. So how do you manage an asthma patient who has been infected by COVID-19? And as you may notice that UK government has now eased the lockdown since the daily new cases graph has indeed begun to fall. However, we're still talking about thousands of new patients here. Do you think the government is opening up the country too early with the consideration that it may cause a second wave? And this question is from UK participant. Maybe you can answer about that. Thank you, Prof.
Thank you.
Yeah.
Thank you, Ogi. So the first of those questions is the easier one to answer. And we've spent some time thinking about how to manage asthma, and indeed COPD for that matter too, in the context of coronavirus. And we're managing it as we would normally manage it. So for example, we would routinely give steroids to someone with asthma who's coming in with an asthma exacerbation associated with coronavirus, whereas we would not routinely give steroids to someone who is coming in with COVID pneumonia. So I wouldn't not use steroids because of the coronavirus in someone with asthma, because we know from randomized control trials going back decades the benefit of steroids in asthma. So to not do that throws away all that experience. So we're managing usual problems in the usual way. That's the first thing to say. Secondly, and in relation to the lockdown lifting here, you may be able to see behind me out of the window here in London that it is a beautiful day here in London. And we don't have very many of those here. It's 25 degrees. People are outside. People are enjoying the lifting of the lockdown. I am terrified that we are going to have a second wave. And it is my personal opinion that the lockdown is being lifted too soon. Our staff are tired, fatigued, are really apprehensive about what is being done by our politicians. I hope I'm wrong, but I don't think I am.
Thank you. Interesting. Yeah. The next will be Professor Fiona Lake. It's your turn, Prof. Fiona. Do you have any question and any answer for the questions?
Just sorry. Here's a question. What have we done in Australia to achieve the flattening of the curve? I think we've been lucky. We've had good leadership and a fairly general consensus, but we live in a country where lockdown doesn't mean you're staying in your apartment. Lockdown means you can wander out to the park, but not gather in close groups and work from home. So I think we've been able to, our lifestyle has still been a fairly pleasant lifestyle for a lot of people, despite the fact that we've been locked down. And I think there's been wide support of it. I think that the loosening up of some of these kind of lockdown regulations, it's going to be fairly slow. So something will open up and then 4 weeks later we'll be able to make a decision as to what impact that's had, and then the next thing will open up. So I think we're probably in there for the long haul. I think I doubt New Zealand. I think possibly we're looking at to try and get rid of the bug completely, which is going to be very difficult to sustain that if they want to have any tourists. But I think we'll be dealing with little bubbling up of outbreaks of coronavirus for a long time into the future.
Thank you, Professor Fiona. Okay, now the turn is for Professor Cesare Gregoretti from Italy. Please, Prof. Cesare, you have many questions.
Yeah, thank you, Rasmini. I have a couple of questions. First of all, I completely agree with the colleague of mine from London regarding whether or not to open the cage. Okay, and we have the same problem in Italy. Today, our government decided to open the cage. I mean, open the cage, that means all the intra-regional movements in terms of tourism will be allowed from June the 3rd. And not because I am living in Sicily. And as I told you before, the number of cases in Sicily were very small indeed. I am really scared of this, really scared. Because I mean, the outbreak of the pandemic was too strong in the northern Italy. And I guess that allowing people to move from the north to the south at this time is a mistake. Even I regret for the people who is starving right now because there's no work in Sicily, because Sicily is an island based on the tourism. I guess, my personal guess, I also agree with the colleague from the UK. I hope to be wrong in what I'm stating, but I mean, the problem to open the cage is really a problem. Anyway, switching back to the clinical issues, I have a question for my friend Reddy. I read that you are using iFlow. My question is why you wrote 30 to 40 and non you start from a high rate X60 as we did, and as usually suggested for hypoxemic. The second question is, I know that in the other country, because the helmet was restricted to Italy, and even other countries was asking to have more helmet, we didn't allow to have helmet outside of Italy. But I want to know if any of us have any small experience on helmet CPAP. And then at the same time, I want to reply because I have to switch back because I have an admission in ICU right now. I was just to reply on the proning, and I can tell you that the lucky thing that the patient were able to self-prone themselves, and this happened both using helmet, CPAP helmet, with an helmet was delivered by a turbine-driven ventilator, but also when you use iFlow or even in spontaneous breathing. So self-pronation is easy. patients are able to position in the right position, a more comfortable position. And so I guess it's a really important thing because prone, but because we, as already underlined, and the other guest underlined, COVID-19 acute respiratory failure maybe had nothing to do with a conventional RDS. Thank you very much, Menaldi.
Thank you, Professor. Now, I want to give again the opportunity to Dr. Ogi. He got a message from the CNN. Please, Dr. Ogi. Dr. Ogi, Shogi.
Sorry, my microphone has been unmuted. All right. Thank you, Professor Menaldi. And to all the panelists, beside the healthcare participants, we also have a correspondent from the CNN Indonesia, and his name is Victor, and he deliver questions to all speakers about the new normal lifestyles. So what do you think about the new normal lifestyles in all of your countries? What kind of preparation needed if a country will implement the new normal lifestyle? Because there's still a lot of pros and cons related to this COVID-19 pandemic. And also, what are the impact if we already focus to implement the new normal lifestyles, but we still haven't been able to control the pandemic outbreak in some area? Thank you for all of your answers.
Okay, good question for all the speakers, but we have to wait. The next will be Dr. Puah first before Dr. Reddy. Dr. Puah, please, this is your time.
Thanks, Professor Minaldi. So I think I'll just answer some of the questions from the Q&A first. I think, so most of the questions were about prone positioning of patients in COVID that has been practiced in Singapore, and whether is it done only in severe patients. I think just as my colleague has presented in the ERJ, we actually are starting to prone patients much early on, as little as 2 liters of nasal cannula oxygenation, and we just ask them to self-prone because they're able to do it on their own as many times as possible. And again, we notice an anecdotal increase in oxygen saturation as well. If, of course, patients who are ventilated in the ICU, definitely we do recommend early proning as well. What about the criteria for admission into our ICU? Because we do report quite low mortality as compared to other publications thus far. And I must say that we had the capacity and perhaps the sheer good luck that we are able to bring patients down to the ICU much early on, especially when they are just starting to desaturate, to monitor them in the ICU. Hence, I think partially that's why our so far scores were on the lower side as compared to those that reported they can go up to about 8 to 9, 10. So we do bring them down early. We do monitor them much more closer. And I think just like just to share as well, since Professor Zari brought up the question on high flow nasal cannula, we do start quite a number of our patients on high flow nasal cannula as well, especially in the ICU. We start them quite at the high flow at 60 liters per minute and targeting a saturation above 92%. So we are seeing quite anecdotally good response as well. And we are analyzing our high flow nasal cannula data. And we've collected it from the other hospitals as well and hope to find something quite interesting there, and whether we are able to prevent intubations and even get them better faster. So I think I answered most of the questions that were from the Q&A. I think with regards to the question from Ogi, the new norm in Singapore, it's probably going to be mask up all the time. Everybody needs to scan their temperatures, and every time we enter anywhere, we have to check in via our mobile phones and check out as we leave. So what we're doing now is that even if you enter a shopping mall, we have to check in. And within the shopping mall, if you go into a supermarket, you have to check in that supermarket and check out. I just got my hair cut today. I had to check into the salon. After they cut my hair, to check out, and then so forth. And then we have to do that. School children are expected to wear masks and visors as well. And I think the new norm is to be prepared to go back into the circuit breaker where we are all quarantined back at home again, which I think the nation is quite prepared already at this juncture, because I think we all see the good and benefits of it. And yeah, so I think that may be the new norm for us for the time being. We hope that we don't have to go back into the circuit breaker again, of course. And you know, as the doors start to open, as the airports starts to open, I think we have to really watch the situation much more closer. I'm happy to answer any other questions otherwise.
Thank you, Dr. Pua. Now is the turn for the Professor Venu Gopal Reddy. Please, Professor Reddy.
Thank you.
Including the question from Professor Cesar.
That is correct. First is regarding helmet. As you, Cesare, remember that America FDA approved helmet only a couple of years ago, so it's still not that common in most institutions, including my own institution. So I don't think America is in a position to talk much about helmet management in the COVID. Secondly, high flow nasal cannula. In the beginning, our hospital policy was up to 60 liters. Then we realized that we were ending up with a lot of patients who were ending up with hypercarbic respiratory failure. And now we have cut that number to anywhere between starting from 10 liters to going up to 30 liters per minute. And the FiO2 is always below 60%. Then we are a bit more careful, or we switch them to non-invasive ventilation. We also put them on early awake prone positioning. But I must also say that in some of the big university hospitals like MGH, I think they have completely stopped using high flow nasal cannula. They look at nasal cannulas followed by non-invasive ventilation, followed by mechanical ventilation. I hope that Cesare, that answers your question. Now, there were some questions from the participant directly addressed to me, and there were some questions from the participant addressed in general to the panelists. So I will try to answer some of them. Anticoagulation is a problem, more so when the patient has multiple organ dysfunction like respiratory failure, liver impairment, or kidney failure, etc. We tend to target their APT level quite high, somewhere around 75 to 90 seconds. And despite this, we had seen some clotting. But unfortunately, in some patients, it has also resulted in intracerebral bleed. So one has to be very cautious how they manipulate the anticoagulation system in these patients. The other question was, Dr. Reddy, my patients recover from respiratory failure, but then he has a cardiac issues. What is your suggestion? As I mentioned to you, by day 4, usually the cardiac symptoms can manifest either in the form of myocarditis or in the form of cardiomyopathy or in the form of a Tokosobo syndrome or a cardiogenic shock. So one has to be looking for it, identify the problem, and treat appropriately. And this can be done by utilizing a troponin level or by utilizing a transthoracic echocardiography. But appearance of a cardiac issue along with COVID also denotes sometimes a poor prognosis. People ask me generally about the role of convalescent plasma. One has to be careful. Just because it has antibodies, you can safely give. Honestly, we had a couple of cases where patient after receiving, one had a trolley and one had a TACO. So we had to be careful that it is not completely free from complications. It also has its own complication. You need to identify a patient who has been proven positive COVID-19, wait for 14 days, make sure he's no more COVID positive, then collect his plasma, and then you can transfer to a patient who can accept it. So it's not a straightforward like giving a blood transfusion. There are many limitations, and a couple of large randomized studies in USA itself is going on. Some of you asked me a question, generally for everyone, role of lung ultrasound. There was a study which came, we also do it routinely in the emergency room, because by the time I see these patients, they're already in the ICU, but routine ultrasound could help to differentiate an aggressive COVID versus a non-aggressive colon. Some people ask me, how do you minimize secretions from the patient? This was a question to me directly in our ICU and probably in majority of the ICU in the hospital where people are listening to this conversation. They have a negative pressure. As a result of it, it is possible that you are going to minimize the secretions from the patient. Suctioning, endotracheal intubation, inflation of the cuff, everything becomes a closed circuit. So there is not much secretions coming out of the patient when he or she is intubated and mechanically ventilated. Regarding hydroxychloroquine, we have stopped using it and we are no more using it in view of increased cardiac arrhythmias and sometimes prolongation of the QT interval in association with azithromycin. A question about prone. Yes, we prone every patient who comes to hospital with hypoxia. We tell them to go on awake proning, which is very easy, and then they can lie as long as they are comfortable. Some of them listen to iPhone music, iPad, or radio, what a book, whatever it is, but we encourage them as much as possible. As far as when do we prone them on mechanical ventilation, we use the same guideline that came in 2013, ProSiva guideline, management of ARDS patients with prone positioning. There was a question about procalcitonin. Yes, we do routinely procalcitonin. Consider utilizing an antibiotic based on our community surveillance once the procalcitonin level is above 0.4. Even above 0.25, we are looking into seriously, but by 0.4 to 0.5, we will definitely start them on antibiotics. There's a good question about telemedicine. USA has moved towards telemedicine in terms of screening patients from home if they're coming for anesthesia or if they're coming for surgery or family. That's another thing because most hospitals, I'm sure in every hospital, family members are not allowed anymore in the ICU. So how does a patient communicate with family? We have Zoom meetings, we have meetings them over the video conferences, we meet them, we talk to them. Sometimes the patients are in a position to talk, but if the patient has been intubated, we take the family permission, we show them the video and we talk to them. Everybody talks to them because that's the only way to keep in touch with the family. Previously, in our hospital, anybody could walk into hospital, be with the family members, except when the nursing changing over or taking place in the morning or in the evening. Otherwise, we have absolutely no restriction for family members. But now that has changed because we have restriction. So we tend to go by telemedicine, talking to family and their family practitioners. One last question about D-dimer. Yes, we use them routinely, and we also consider utilizing other parameters like ferritin, LDH, IL-6. That's where all my questions end.
Thank you, Professor Reddy. Dear participants, I have to end the session. This Respina Global Sharing is very interesting. I know there are some questions, including for me, I think, but we have to end this because it's already time concern. And all the questions will be also noted by the host. And I hope that all the speakers will continue answer it after this session. Okay. My apology for this, and thank you so much for all the participants and the speakers. And please allow me to make a conclusion. The first is that it is good that this in pandemic, the government should fully control the condition. The second is that we all have to focus on the slope. We have to make the slope and really focus on the slope. The third is we have to make a really close observation, day by day, close observation. Then we know where to go and where is our position now. The fourth is innovation on oxygen delivery system, respiratory and ICU care is very important because this is a pandemic of the infection in the airway. And the last is about the new normal. every country has their own specificity and their own ability to adopt with the new approach. So maybe the new normal cannot be the same, really the same for every country, but every country has to adopt how the new normal approach is going to be done in their own country. Thank you to Dr. Daeng, the President of the Indonesia Medical Association, to Dr. Wahyu Ningsi, who allow me to chair this session as the President of the Respina. Thank you to all the speakers, the Respina faculty members, and also to all participants, including from abroad, from outside Indonesia. And thank you to Daria Faria, who supported this in a very, very well coordinated. Thank you. And I give it back to Dr. Diki.
Thank you very much, Prof. Menaldi, and all of our speakers. It was a very interesting discussion, and now we have reached at the end of our webinar.
To all participants, if you have registered, please remember to fill and submit the post-test for electronic certificate after the webinar.
Thank you so much for joining us in this webinar, Respina Global Sharing in COVID-19 Pandemic. We hope everyone gets valuable knowledge. And
see you again
in
another Respina webinar. Good night and have a great weekend.
Menaldi, I have a small question.
Yes, please.